Okay, I'm going to make a start, everybody. It's just 1 minute after. I'm sure that people will still be joining us as we kick off. But I'd just like to start off by saying I'm Andy Field. I'm the chairman of the Trust, and I'd like to welcome you all to this annual members meeting, and being done virtually again. I think we get more representation that way, which is a very, very good thing. I would like also to welcome Julie Smith, our Chief Executive, to her first annual members meeting. And you'll hear from her, and you'll hear from our lead governor, Shirley Holmes, and indeed the rest of the executive team as we go through. And they will introduce themselves as they come on to each of their bits. So just a small bit of housekeeping, please, first. If you could keep your mics on mute, that'd be great. We'd love to see your faces, so feel free to keep your cameras on, but it would be good to keep the mics on mute, otherwise these meetings get a bit distracting. We will be answering the questions that have been submitted at the end of the presentation, and I'll answer those that have been submitted in advance first, or rather I will put them to the people best placed to answer them first. Then if there are any questions that you want to put in the chat, we will pick those up. And finally, time allowing, please use the yellow hands function on Microsoft Teams to put up your hand, and we will do live questions. As I say, it'll all be dependent on timing because we do need to run to time today. So just please note that some of the images in the presentation that you'll see were taken when wearing masks and social distancing wasn't mandated. So you'll get a mixture of pictures, so don't think that we're not wearing masks or that we are wearing masks at a particular time. These are obviously reflective of a full year where our IPC requirements have changed and are keep changing over the year depending on the COVID situation. The majority of the presentations will be a look back at our work in the financial year 2021-22. This is a legal requirement. We have to present to you what we've done and our financial position in that year. And Julie, when she speaks, will give a quick update on the current position and a look ahead. You'll get a look ahead, don't worry, as we go forward to say where are we right at the moment. So that said, anybody who isn't on mute, I think somebody is out there not on mute, please mute yourself. And we will go on to the presentation. So next slide, please. So I'd just like to introduce you to members of the board because there have been some changes since last year. So I'm assuming that you can all read what's there, but I just wanted to particularly highlight members that have changed since last year. And of course, I have to start at the top with Julie Smith, our Chief Executive, who joined us in May last year. And a big welcome to her. And her and the executive team are at the bottom of the slide there, and they are the people who run the trust day to day, bear the heavy burden that is looking after all of our patients day to day. Up the top are the non-executives. You may think that, my goodness, we outnumber them. There's a good reason for that. But I'd like to, first of all, welcome, since last year, John Machin, non-executive director, who's come in to chair the Modern Healthcare Committee. John is an ex-KPMG partner, and he's also a non-executive with our colleagues over at CSH Surrey. What we like to do and what the governors are very keen on doing is us bringing in people slightly ahead of time when non-executive terms are finishing, so that they can get up to speed for the time when people leave. And Chris Ketley, who is third from the left there, will be leaving us in February, and he is our digital NED and chairs our digital committee. And I'm pleased to say that Donald Iro is the non-executive director designate who has joined us now, coming up to speed, attending the meetings, etc., and will take over from Chris when Chris departs in February. And then you will see Soma Champaneri at the end there. Soma we have taken on as an honorary non-executive, so that's not a voting member of the board, but to give her some experience at board level. We were very impressed with her at a recent NED recruitment, and SOMA's agreed to do that. We've done this, those of you who have got good memories will remember we did this with a lady called Yvonne a few years ago, and she then went on to be a very successful non-executive elsewhere. So we're delighted to have SOMA join us as well. So that's the board and the changes from last year. So next slide, please. So as always, we've been very busy. I say this every year, but we certainly have. We serve some 400,000 or so local residents. Our turnover, which is the taxpayers' money that we look after on all of your behalf, has been 425 million in that year. And Simon Marshall, our finance director, will go into a bit more detail on that later in the presentation. You'll see that our attendances at accident and emergency still very, very high. People coming through our urgent treatment centre and our A&E, 120,000. That grows year on year. Obviously, it changed a little during COVID, but it's definitely a huge demand at the front door. We're delighted, of course, to help deliver 3,349 new lives into this world with the mums, supporting them. And of course, lots and lots of outpatients, including those seen through virtual means, which was so important to us in the pandemic. And you can see the number of urgent admissions by ambulance as well. So a busy old year. Next slide, please. So our services, and there have been some changes on our services. So St Peter's remains our urgent and emergency care centre. So maternity is here, accident and emergency services, intensive care, both for adults and the neonatal intensive care. Clearly, obviously, outpatients, etc., and pathology services, all at the St Peter's site. But at Ashford site, Ashford saved us during COVID. Let's be really clear, having a separate facility that we could run as a clean, or green as we called it, facility was immensely helpful to us during COVID. And I'm delighted to say, and this will be covered later on, that we have won some funding from NHS England to have the Surrey Elective Centre at Ashford, and that will be for knees, hips and eyes, basically. So Ashford, really important to us going forward. Still doing the day case surgery. It will be the Surrey Heartlands Elective Centre. Still doing a lot of ophthalmology, outpatients, etc. So a lot going on at Ashford Hospital. We'll be happy to take questions on that later. So next slide, please. Obviously, we're not just in our main hospitals. Woking Community Hospital, we've got a neuro rehab ward at Woking. We do outpatient services and physio from there, and indeed we will be shortly doing new diagnostic centre from Woking. So a lot happening at Woking that will help the residents of Woking not having to come to St Peter's or Ashford as frequently as they have, because what will be happening at Woking. And lots, I won't go through them all. On the right hand side there, specialist clinics within the community. We're especially proud of our outpatient physios that run out of Egham Orbit, that run out of the Riverbourne in Chertsey and out of the Woking Community Centre that actually are really close to patients. So cutting down travel time, modern facilities, gym facilities, the physios love them, patients who go there love them. We're really proud of that. So the next slide, please. So I've probably said enough as a starting point, and I would now like to introduce Shirley Holmes, who is our lead governor, and she is the public governor elected for Woking and Guildford, just newly re-elected, I should say, as well. Shirley.
Good evening, everyone. As Andy said, I am an elected governor for Woking and Guildford, and I'm also the lead governor here at the Trust. Next slide, please. Ashford and St Peter's is an NHS Foundation Trust. Foundation trusts are not-for-profit corporations established under the three acts which are highlighted on the slide. Foundation trusts have a public membership, a council of governors and a board of directors, but it is the board's responsibility for running the trust. Next slide, please. Our Council of Governors is made up of 24 governors, 14 public, 5 staff and 5 appointed governors. Public governors are elected by members of the Trust, staff governors by members of staff from the relevant staff group, and appointed governors by the body that they represent. Next slide, please. Governor details can be found on the main notice boards by the entrance to both hospital sites, and also full details on the Trust website. Next slide, please. The Council of Governors has a statutory duty to fulfil a number of duties, and these are as follows: to hold the non-executive directors to account for the performance of the board, to represent the interests of the general public, and this includes patients and members, to approve certain large transactions, to appoint the Trust's auditors, and to appoint non-executive directors, and this includes the chair, and agree remuneration for all of them. Next slide, please. So what have we been doing this year? It's been a really challenging year for us due to COVID restrictions. We've had to work very differently, and most of our meetings were held online rather than being face to face. However, we believe we've still managed to fulfil our duties. So what have we been doing? We've held the non-executive directors to account via Council of Governor meetings and non-executive director meetings. We've approved the appointment of the new Chief Executive, Julie Smith, and we were delighted to welcome her to the Trust in May. We've also appointed the Trust's external auditors, KPMG, and 2 new non-executive directors who Andy spoke about earlier on. We've also endorsed the Chairman's appraisal and non-executive directors' appraisals. Next slide, please. In addition to our statutory duties, governors have been able to get involved in a wide range of Trust activities, and these listed include some of them: the Pride in Nursing Day, the Staff Awards Ceremony, which I'll speak a little about later, and quality account workshops. We've also been able to take part in walkarounds and tours of several hospital departments. These were reintroduced in September following some relaxation in COVID restrictions. We've contributed to the Trust strategy refresh, and we've also taken part in the well-led review. Next slide, please. We've also made a revision to our constitution and merged the Rest of England seat with one of our existing seats. Next slide, please. As you'll see, we've recently held governor elections for 11 public and 2 staff governor seats. Thank you so much to all of you who have taken time to vote in these elections. Some of our governors decided not to stand for re-election this time around, and I'd like to take the opportunity to thank those who will be leaving us at the end of this month. Hina Malik, Colin Hood, Emma Gilmore, David Carpenter, Derek Barnes and Matt Stevenson for their contributions during their term in office. Details of the new Council of Governors will appear on the Trust's website sometime early December. Next slide, please. I was recently asked what were the main highlights for me during the last year, and 2 things really stand out for me, and both relate to our workforce. I was invited to attend the Staff Awards ceremony last month, together with some fellow governors, and what an enjoyable afternoon we had. We have a diverse and talented workforce here at the Trust, and it was a real privilege to meet some of them and learn why they had been nominated for a award. Finally, COVID is still very much with us, and demand for our services remains high. Our staff, Team ASPH as they're known here at the Trust, face challenging decisions and situations every day, and they continue to work together to provide quality care for our patients. On behalf of the Council of Governors, I would like to thank Team ASPH for their continuing commitment and dedication to their work. I'd now like to hand over to Julie Smith, our Chief Executive.
Thank you, Shirley, and good evening, everyone. So I'm Julie Smith. I'm the new Chief Executive, not so new really. I've been here for quite a few months now. I came in May and I definitely feel part of Team ASPH. So this is my first annual members meeting and I'm absolutely delighted to be with you. If I could just have my next slide, please. So in this section of the presentation, I'm outlining the trust strategy, and then each strategic objective will be presented by the key executive director leading on that particular area of work. So you can see those 5 strategic objectives on the screen. So our trust strategy, Together We Care, was launched in May 2018. It was developed within the national and local context of a mandate for collaboration and partnership working to foster strong foundations for creating and benefiting from strategic opportunities, resulting in improved patient care. The context for our strategy as part of this annual report aligns very much to the challenges of the ongoing pandemic, and you'll hear about that later in the presentation. Our vision to provide an outstanding experience and best outcomes for patients and the team remains true and is underpinned by our core values. Our mission to ensure the provision of high quality, sustainable healthcare services to the communities we serve. And this remains core to everything that we do. The strategy remains consistent with local policy, the Surrey Health and Wellbeing Strategy, North West Surrey Alliance, and the NHS Long-Term Plan, and working in partnership and collaboration for the benefit of all our patients, relatives, carers, and staff. And you'll hear a little bit later in the strategy section from Tom about our strategy refresh as well. So at this point, I'm delighted to hand over to my executive colleagues to give an overview on the progress within each strategic objective in the annual report. And we're going to kick off with quality of care and Andrea Lewis, our wonderful chief nurse. Thanks, Andrea.
Thanks, Julie, and good evening, everybody. Lovely to be here. So, as Julie said, I'm going to talk about the quality of care strategic objective, and we're doing lots of work within the trust to support this. But there's 3 elements that, or key elements, I really want to draw out, which are illustrated on the slide. The first one is about the main effort, which I'll talk about a bit more in a minute. The second one is about preventing hospital associated harm, and then the third one is around our North Star objective. So the first one then, our main effort, as it says on the slide, this is to ensure that patients reside with us are only the ones that will benefit from our care. So in essence, this is all about ensuring patients are on the correct pathway as quickly as possible. So it's all about patients receiving the right care in the right place at the right time, and there's a real focus on this from our perspective around criteria to admit, basically only admitting those patients that really do need to be admitted into our organisation, and a criteria to reside, i.e. those that are with us are only the patients that really do need to receive treatment and care, and those that no longer need that then do get discharged in a timely way. And we've had 3 phases around this main effort. The first phase, phase 1, has been a piece of work that we've done about realigning our beds within the system. So this has been about reducing some of our beds within the hospital to then increase beds within the community. So that realignment piece. Phase 2, which is still ongoing, is a real focus on our urgent care delivery. And one of the examples that I'd just like to highlight with regards to this is the introduction of a navigator role within our emergency department. So if you were to come to our emergency department, you would be greeted by one of our navigators who would check out obviously what you're presenting with, but then would basically signpost you to the correct area within our urgent and emergency care footprint. And then phase 3 is basically further bed alignment that we're doing. And this is particularly looking at our surgical beds configuration and what we have on St. Peter's site and what we have on Ashford site. And as Andy said, Ashford has become a surgical hub for us. We do have some medical beds, medical wards over at Ashford. So we're looking to bring those basically over to St. Peter's. So we've got all of the medical emergency beds over on our St. Peter's site. So lots of good work going on around that, and Essence will improve patient experience without a doubt. The second bit that I want to talk about is about preventing hospital associated harms. And as the picture states there, this is an umbrella, and basically that umbrella brings all the different harms that can happen to patients whilst in hospital, sadly. That's of falls, pressure damage, malnutrition, and venous thrombolytic embolism, which basically blood clots. And as nursing and medical staff and clinical staff, we do a lot of work around this to ensure we prevent these harms happening to our patients. And we've brought all of those different harms under one umbrella, delivered by one core team, headed up by our brilliant nurse consultant, Sue Harris. And there's lots of great work going on around this with lots of oversight groups as well. And then the third bit to bring out around how we're supporting the strategic objective of quality of care is around our North Star objective. And we did mention this actually at our last annual members meeting. And this has been basically born out of COVID and is around our really strict infection prevention measures that we did bring in right at the start of lockdown in COVID, that we've continued with because we've had such great success with this. But the main aim around the North Star objective is basically a zero tolerance to any hospital acquired infections. So as I said, some born out of COVID, but it's not just about COVID now going forward. It's about all infections and ensuring that our patients don't come into our organisation and pick up an infection. It's a key quality priority for us. As I said, we've had some really strict protocols and practices in place with COVID that we've continued with, and it has definitely delivered some really great results for us from a patient experience perspective. Just bringing out COVID, we are, as a trust, in the top 10 performing trusts that have the lowest COVID hospital acquired transmission in the country, and we're very proud of that. And again, that's really around this North Star objective in our IPC strategy that we've had implemented. So that's the top 3 things that I wanted to cover off for this strategic objective. I'm now going to hand over to James Thomas, our Chief Operating Officer. Many thanks.
Thank you, Andrea. Good evening, everybody. I'm James Thomas. I'm the Chief Operating Officer here at Ashford St. Peter's. I'm just going to talk to you about the 2 big issues that sit under modern healthcare, which is our urgent care delivery and our elective services. So in 2021, we had a very busy year for urgent care. This was our first year of post-lockdown. And as a result of the lockdown activity, we saw an influx in urgent care after that period when people were able to sort of mix in society. And we saw that through increased attendances through A&E, about 10,000 more attendances in this period than the year before, which is about 8% increase. We performed well against that in terms of the 4-hour standard, so still above national average. We had 2 exciting developments in this period. So we were very fortunate that during the COVID period, we got a £15 million block of money from NHS England to develop further our emergency centre. And there are 2 key parts of that. First is our ambulatory emergency care unit, what we call our ACU. And that's an important facility where we can manage people who require care but can go home on the day. So we've got a bigger facility to look after those patients. Immediately before that, we were seeing about 800 patients turning them around on a day every month. Immediately after, that grew because we had the facilities to do that, to over 1,000, and now we're at about 1,300 a month. So that's really allowed us to treat patients in a more appropriate environment and work on avoiding inappropriate admissions and able to turn people around on a day. So that's a really important part of our main effort that Andrea described. The other thing that we developed as part of that £50 million was our clinical assessment, combined assessment unit. And that brings together our surgical unit that we had, a medical one we had. It brings all of our clinicians together in the right place to form a robust, strong, safe, effective environment following A&E as part of the emergency care pathway to make things more efficient for our patients. So there are two really important developments, and there are two of the photos here. You can see that they are the two photos of the clinical areas are our new ward area, which is really, really good environment, some of our best ward stock in the organisation now. The next thing we had was our elective care, and we had a number of things happen during this period. Post-COVID, it was really important for all of our patients to work on how quickly we could get waiting times back under control. The 18-week standard doesn't exist now. It's not measured now because we're so far away from it, but the first standard that the government put in place was a 104-week wait. We've never had patients at that level, and the first ambition was to get all patients over that target treated, and we still haven't had anyone over that wait. So that's something to be proud of here at Ashford and St Peter's hospitals. We've had some developments in our elective centres. So as the chairman described, looking forward to the of what the future Ashford holds is really exciting, but the roots of that came in the financial year. We're looking at 2021. We put an extra ward in at Ashford, or developed a space to be a ward, which we call Elliott Ward, for elective surgery. We developed an additional theatre at Ashford. And so at that point, we were able to move elective surgery over to Ashford from the acute side and try and have a dedicated site where we did our elective work. So it was away from the acute site, doesn't get interrupted by the urgent care flows, causing people to be cancelled on the day. It enabled us to keep elective patients away from COVID and other infections. So that was the groundwork, that was the basis for what's now expanding into a greater role across Surrey in terms of the elective centre. So it's a really exciting development, and these were the foundations to enable that. And the last picture we have here is of our therapy services. So this was a hugely successful initiative. It started the year before with moving therapy services to Riverbourne. They're one of the local gyms. And during this year, we expanded that to two other areas, Woking Leisure Centre and Egham Orbit. And this is where we offer physiotherapy outpatient consultations and outpatient work in a gym environment. In fact, the majority of our IMSK therapy consultations are now offered in that environment, about 300 a month. And during this period, we expanded it to using hydrotherapy. So we used a swimming pool at Woking Leisure Centre, and also expanded it to cover peds as well. And that's what this photo here is of just one of the exciting developments we had in the elective care part of the organisation. So that's it from my slides on the strategic objective of modern healthcare. And I'm now going to hand over to Louise McKenzie, Director of Workforce.
Thanks, James. Under the People's Strategic Objective, I'm going to focus on wellbeing and recognition, recognising that improving the experience of work for colleagues has a positive effect on the quality of care they provide for you as a patient, service user and family member. So we continue to expand our wellbeing offer, and you can see the breadth of this from the infographic on the slide. This includes financial, environmental and social wellbeing, to name a few. The COVID pandemic shone a light on the safety and wellbeing of NHS workers and highlighted the need for us to have a well-rounded offer to support, in particular, emotional wellbeing. And some of the interventions that we've now got in place include a self-referral service that is provided free to all of our colleagues via the Surrey Heartlands Resilience Hub. We expanded Lawrence Gamlin, who's our chaplain, we expanded his role and he became the staff wellbeing and pastoral care lead, offering one-to-one and team support. And in order to make sure that Lawrence gets to the difficult parts of the organisation that sometimes are hard to reach, He introduced a wellbeing wagon. You may see him delivering refreshments and snacks out to the ward and departments. It's also an opportunity for him to have a quiet word with somebody, a kind word or a listening ear. And finally, we've introduced a new employee assistance programme that provides 24/7 impartial, confidential advice from qualified counsellors. Specifically, this gives staff support, not just around problems they might encounter at work, but also at home, around areas such as bereavement, stress, financial problems, family difficulties, etc. We've also expanded our resources in relation to physical well-being, starting off with some initiatives around exercise, health and nutrition. And you'll see from the slide a picture of one of our wellbeing hubs that we opened in 2021. So giving staff a space to exercise, to socialise and to relax. I'm very grateful for the board for investing in staff wellbeing, but also extend my thanks to NHS Charities Together and Captain Sir Tom Moore for the donation that they made, because we were able to buy some really lovely furniture and equipment with that donation. In 2001, we also commemorated Team ASPH and the extraordinary care, courage and sacrifices that they had to make during the pandemic. And we did that by giving every member of staff a yearbook and a medal. The yearbook is made of photos and stories of our COVID journey for staff to enjoy, treasure as a keepsake, and just be really proud of their contribution at this extraordinary time. The COVID star, which you can see on the top right-hand photo, is a beautiful glass and enamel medal designed by a famous sculptor, Harry Gray. And you can see from that picture that Harry combined the classic shape of the St John's Ambulance Maltese Cross with the COVID molecule bumps. We had a conversation where we said we feel our staff deserve a medal, and that's what you see there on that photo. We hope that colleagues, and you can see it on my jacket and some of the other execs today, we hope that they wear those medals with pride. And finally, you heard from Shirley earlier the highlight of her year, which included attending this year's Staff Achievement Awards. It's a fabulous afternoon celebrating colleagues who've been singled out as going above and beyond. And this year we held our afternoon tea and awards reception at Wentworth Golf Club. You can see the photo of Julie and Andy with the recipients of the 2022 awards. This year's Chief Executive Award went to Ralph Mansour, who is our head of catering, for his impressive transformation of our catering services. And in the photograph, you will see him with his team celebrating both his individual win, but also a national award for Healthcare Caterer of the Year at the catering equivalent of the Oscars, fondly nicknamed the Caties. So on that winning note, I'll hand over to Simon for his presentation on the digital strategic objective.
Thank you, Louise, and good evening, everybody. So my name's Simon Marshall. I'm the not so new, I think it's probably fair to say, Chief Financial Officer here at Ashford and St Peters. But just at the moment, it's my pleasure to present our digital strategy objectives, really. And I wanted to focus really on the first part of that strap line. Can everyone still see it? Is it just mine that's disappeared? Okay.
We've lost the slides, I think.
No problem.
Yeah, we're just
I'll carry
sorting it
on.
out. I think maybe a guest is taking
It's
control,
okay. I
but
can
give us a
carry
sec,
on while
Simon. Thank
That's
you.
okay. That's okay. I'll carry on anyway while they're doing it. So, so the first part of that strapline, the using digital technology and innovations to improve clinical pathways, is really where our new electronic patient record system comes to play, really, and that's called Surrey Safe Care. 21-22 was a massive year of preparation. The actual go live slipped slightly into May 2022, but we spent all year preparing, training and getting ready to implement our new system. The system itself is intended to transform all of our ways of working, including how we manage and share information across the trust and across the wider system as well. This is a shared system with Royal Surrey. We would like that system really to drive the higher quality care and, importantly, for patients and the team, improve safety and experience. Surrey SafeCare, though, is more than just a move from paper to digital records. It really is a transformational change to real-time patient information that's instantly accessible and secure to all authorised users. And that means we can look at data, with multiple users at the same time, for example, and across different sites, particularly where we have complex pathways like cancer, for example. Surrey SafeCare, it holds all of our patient information. And just to give you a bit of a flavour of that, it includes clearly your medical histories, the diagnosis you may have had, your medications, the treatment plans, things like immunisation dates and statuses, allergies, radiology reports and laboratory results, to name just a few. But it really is a comprehensive acute record. The system provides a much broader view of patients' care, and it enables our staff to make better informed care decisions, to do that quickly and to help improve care generally and reduce safety risks in particular. So, for example, healthcare acquired infections, treatment delays that may occur otherwise, and medication errors we're all looking to reduce. Now, on the slide, so you've got the pictures back now. The Surrey SafeCare programme was enormous. At various times, we had 200 extra people across Royal Surrey and Ashford and St Peters in enabling this change. And we took these pictures. This was Sunday, the 15th of May, 2022. It's a date burnt into many of our minds because it took literally the whole hospital, all of our staff, to transfer the inpatient data across all of our wards. On that day, we transcribed, so that we moved our medication records of 31 wards, I think it was, over 21 hours. It was a simply supreme effort. So thank you for everyone who was involved in that. The transformation, though, it's an enormous process, and it isn't something that just happens overnight. We've continued to work on this change process over the last 6 months, and I really should stop and pause and say thank you to everyone, whether that's for your patience as we fix things, or whether that's for your active support, the contributions we've had from across the teams, and particularly the operational teams who've helped us immensely make sure that transformation is complete, really, and so that the system is fully stabilised. Really, that's been our key aim of late. As a team, we do continue to work on certain fixes. We've got a series of sprints. They're quite fast and quick, to sort of every 2 weeks we try and get a load of issues resolved and fixed and tested and rolled out. But there is much more that we're planning, really, and this is where the empowering patients comes in, because next year we're looking to launch our patient portal. That would particularly be useful to patients in terms of looking at their records, rescheduling maybe their appointments, and those sort of things. So there's a lot more to come over the next year, and we look forward to that. But at that point, I'll hand it over to Tom. So thank you.
Thanks, Simon. Good evening, everybody. It's great to be with you, albeit virtually. I'm just going to talk you through the strategic objective around collaboration, including the process of refreshing the trust strategy, which Julie has already mentioned at the start of this section. I mean, we decided to do this, and many of you were involved in the process. We decided to do it during COVID. In fact, in the midst of the first wave, we thought this is going to change things forever, and our strategy doesn't reflect that. And at that point, we said we need to refresh the strategy. The work was really done last year, actually, following the kind of the end of the sort of the big third wave that you'll remember, and many of you were involved in the process. And for those that were, either through attending one of the sessions that we had, I think we talked to around 300 of you in that process, or filling in the survey. Thank you for that. Thank you for your contributions. We've processed all of those together. We took the final strategy refresh document through the board in the summer, and this week we are publishing it. So it's really good to get to that stage. And as I say, thank you to everybody who's been involved in that process. So we're publishing a strategy which is based on our Together We Care strategy, and it's a strategy for 2022 through 2025. And as Julie's already said, the strategic objectives remain intact, although they've all been updated, because clearly COVID has impacted us heavily, and new legislation in the Health and Care Act has come forward this year as well, which has also changed things significantly and provided us with some great opportunities around collaboration, which I'll say a little bit about in a minute. Our vision, our mission, our aims as an organisation have also remained intact through that process, which is really good to know that actually they have withstood the test of COVID, and that people that you think they are still the right vision, mission and aims, and in particular around the mission to provide high quality, sustainable healthcare services to the communities that we serve. We're now turning that into, or taking that as the basis for our clinical strategy, which we're in the midst of developing at the moment. So thank you for being involved in that. We're going to be, as I say, publishing the strategy this week. We're going to be encouraging people as part of that process to come forward as members, because our membership is really important to us, and in particular we want to find ways to encourage some of the younger members of our community to be members. So I'll take this as an opportunity to ask you to think about keeping it in the family and encouraging your sons and daughters and grandsons and daughters to come and join us as members. Anybody over 14 can be a member, and it's a great way of getting to know your local healthcare system, your local healthcare trust, and to access some of those fantastic opportunities that offers. So you'll be seeing our strategy very soon, our refreshed strategy. Our collaboration work is going at some pace now, and I'll just talk about the collaboration. We do lots of collaboration, but I'm going to talk in particular about North West Surrey Alliance, which is what we call our place collaboration, the place where our community is, the population that we predominantly serve, and a little bit about the Surrey Heartlands Health and Care Partnership that we are part of. Our place partnership, which is 11 organisations across the health, care and local government sectors, is a partnership which has been thriving actually for a number of years. We signed up to it formally in December 2020, but a lot of the individuals, relationships and organisations have been involved in that partnership for a long time. And a number of us took some time out at the end of September to reflect on what our service strategy model going forward is. And the importance of putting together health and care and well-being professionals, volunteers, charities, faith groups at a neighbourhood level, and building a team around individual neighbourhoods, which is the work that we're now taking forward as part of delivering that service model. We're looking at how we implement the business units that will deliver that, and how we will wrap around people who are at risk of going into a crisis or entering healthcare services within their area, with access to things like social prescribing, voluntary support, the support of people with lived experience around particular issues. All that will be happening over the next year. Another thing that I just wanted to mention is the development of the Woking Community Diagnostic Centre, which we were successful in our bid for funding for, which will see a range of diagnostic equipment and services going into Woking Community Hospital to add to the diagnostic services that we already provide through Ashford and at St Peter's, which is a really, really interesting, exciting development for Woking and for the hospital there, and there'll be a new build associated with that. So some really fantastic work happening within North West Surrey Alliance. And just finally on that is also contributing to what Andrew's described around our main efforts by enabling us to put in place more capacity in the care sector and actually consolidate the beds that we're offering within the hospital so that people can be treated in the right location and not subject to the risks that exist by being in a hospital when you don't need to be. And then just finally, our Surrey Heartlands partnership. Surrey Heartlands is the Health and Care Partnership, which was brought into being through the Act of Parliament at the beginning of July this year. It's a partnership between health and local government operating at the Surrey level. It provides us with new opportunities around collaboration with our other acute partners and the mental health trust within Surrey Heartlands. Simon's already mentioned the Surrey Safe Care project, which we've done in collaboration with the Royal Surrey, but which actually offers us a collaborative platform, a digital platform across all the acutes within Surrey Heartlands. The ability to collaborate with other hospital trusts enables us to tackle that challenge of service sustainability. And those services which are challenged because of workforce issues, because of demand outstripping supply, because of the need to invest in buildings and facilities, actually there is real opportunity to put those services together with other services provided by other trusts to overcome some of those challenges. The elective centre at Ashford, which serves Surrey Heartlands, and James has already outlined that, is really the first major example of us doing that, bringing together those services for hips, knees, for eyes, and over time, I'm sure other surgical services to enable us to offer that to the widest population. And we're looking as part of our clinical strategy work for other areas of collaboration that we can pursue with our acute partners. So it's a critical part, really, of the future sustainability of our trust. So with that, I'm going to hand back to Simon to take us through the finances. Thank you.
Thank you, Tom. I think the slides there, that's just the introduction. So we've done that. We can whiz on if that's okay. So on my first slide, really, I just wanted to talk us through the sort of headlines of the financial performance. Clearly, there's a lot more within the annual accounts and report, which we can no doubt answer questions on later if required. But essentially, the last couple of years were under COVID sort of conditions. As a result, the NHS was in a kind of command and control mode, I guess you would call it. But essentially, we were required to break even. You can see from the chart with the blue bars on that so before COVID, we had a small surplus. In the first year of COVID, we did actually break even. There's some technical adjustments around the revaluations of our land, which don't count. So we met that control total. And in last year, 21-22, we reported a surplus of 6.8 million. That was driven by the late receipt of some extra income in terms of our elective recovery kind of funding. So again, that was welcome funding, but not something we'd necessarily planned for during the year. So I'm really pleased to say that we've continued to meet those control totals, the financial targets that are set for us. So that's the good news. The challenge really is obviously during COVID, I think all NHS organisations received substantially more funding than certainly we had as we went into there. And clearly that funding is going to be slowly withdrawn and we do need to manage our resources in line with the available funding on a kind of future basis really. So just to highlight that, but I'll move on if I may. Thank you. So 425 million, oops, disappeared again. That's what we earned last year. The sources of that are clearly the vast majority does come from NHS funding. We do receive small amounts of other funding, whether be it's for education and training or maybe private patient sort of income. And we do generate obviously some sort of income generating activities. So car parking income would be an example of that, which obviously all goes back into supporting the hospital and its services ultimately. Again, is it just me that's missing the slides or is everyone? I think I'm jinxed tonight, but I'll carry on.
Simon, I can see them.
You've got them? No problems then? All right, in which case I will carry on. I've got a spare copy. So just moving on to the next slide, it should be what we spent our income on there. And you see a kind of column of charts there. So we spent 417 million. That was up 7% and from about 390 million the year before. As normal, 2/3 of that goes on staffing. So be that their actual pay or pensions, for example. We spent about another 15% on our clinical supplies, drugs, all those things required to support our activities. We do spend some money with the wider healthcare system, so that might be with other healthcare providers like Royal Surrey, for example, or St George's for various services, but also in the private sector as well. So Alliance in Health, as two examples, provide our MRI and cath lab services. And it's always one that people are quite keen to look at. Our clinical negligence costs were again up slightly last year, but that's 15 million of our overall turnover goes on essentially insurance to pay for claims where problems have been encountered with people's care, obviously. So I'll move on again, if I may. Again, I can't see them, so I'm going to assume it's there. The next slide was just to, I guess, highlight some of the investments that we've been making over recent years. So on the slide in front of you, that you should have the 21-22 area. So you can see the year in question we invested in Surrey Safe Care, some of our clinical assessment units, so the two new ward facilities that went in next to the emergency department were big additions last year. We've it's not actually our money, but with partners, our staff accommodation, it opened, or the first phase of that opened recently, and again, significant investment going in on those. And then we spend huge amount of money each year, probably towards 10 or 11 million on kind of backlog expenditure, really. So that goes on health and safety and fire, various rolling replacement programs and IT and all the stuff that we need to replace every year. Looking forward into 22-23, you can see a bit more of our plans. So things like ward refurbishments are in there, the Surrey Elective Centre. Again, Julie will mention these later, but we should be starting to invest in that, and that should be open next year. And looking forward into next year, again, further phases of Surrey Safe Care, more ward refurbishments and theatre refurbishments next year are planned. And we're starting to look at maternity and ED in a much more significant way to make sure they are kept well, they're improved, really, I guess, with the investments there. So at that point, I think I'm done, and I should be handing over to Marcin.
Yep. Thanks, Simon. Actually, let me just introduce Marcin Waterman, our Deputy Chairman, and Andrea Lewis, Chief Nurse, and they're going to talk about a really exciting programme. And actually, those of you who've been on Twitter today will have seen that we had a very exciting event in the foyer of St Peter's today, which is all to do with the Healing Arts programme, and I won't steal their thunder, but I'm going to hand over now to Marcin. Thanks.
Thank you very much, Andy. And could I have my first slide? So we know that the arts can help us.
You've muted, Marcin.
Now that spoils my intro. I'll start over. Sorry, people. The arts can help us live well. It can aid our recovery, and we know that it can support longer lives lived better. But what's the context for how this program came about? 2 years ago, there was an all-party parliamentary inquiry about the impact the arts can have on our health and well-being. And a report came out that had compelling evidence that creative and cultural activities have a positive impact on health. So recommendations included that every NHS trust should pursue a policy for the arts and health, and they ought to have a non-executive director champion that policy. Well, that's me currently, and I, as Andy says, very passionate about our program. Can I have my next slide, please? So there's as I mentioned, there's a plethora of evidence that indicates the arts, but in its widest context, has a positive impact on clinical, emotional, and social outcomes for our patients. This body of research supports the case that arts can play an important contribution. And on this screen are some of the known benefits, including reducing length of stay, reducing use of medication, and promoting better care of our environment. Engagement with the arts, I truly believe, improves the humanity, the value for money, and the overall effectiveness of what transpires in our hospitals. My final slide, please. So our Healing Arts program was started 2 years ago, but has been relaunched since COVID. A lot of our activities had to be put on hold for obvious reasons. It's solely funded by the Ashford and St. Peter's charity. So any donations any members would like to make to further our program after you hear the exciting activities, we would be ever so grateful. Our program has 3 strands: music and theatre, the performing arts, the visual arts, and the improved architecture, including the nature and the built environment. In some of the slides you've already seen from our executive colleagues, you'll have seen some of the impact we're already having in areas of the hospital. Andrea is now going to share with you what we've actually delivered so far and some of our real key projects that are on target for this year. Thank you, Andrea, my cohort.
Thank you, Marcine. So the first, as Marcine's already mentioned, the first strand of our Healing Arts programme is that around music and performing arts. So launching our live music programme this month is part of the ongoing work to improve patient experience and outcomes through the presence of art in all forms across the trust. And we believe, as research shows, that live music helps people feel relaxed and confident and can relieve frustration, stress and isolation. And a recent study conducted by the University of Huddersfield and the University of Sussex in partnership with the charity Music in Hospitals showed that people who experience music in a clinical environment definitely experience a decrease in anxiety, a decrease in the level of stress on the body, and an overall increase in well-being. So it's a bit of a non-brainer, really. So to mark the return of live music within our organisations, because we did do a little bit of this before COVID, but obviously since coming out of COVID, now we've relaunched it. We have purchased a new baby grand piano, which is situated in the main entrance now of St. Peter's as you come in. And we launched today, as Andy's already said, our reinvigorated live music with a performance by one of our executives that we've just seen, Tom Smearden, who played a 20 minutes recycle actually on our piano, which I have to say was absolutely brilliant, and he is a real talent, that's for sure. So thank you, Tom, for that performance today, and it was very, very well received for who was watching there in the main entrance. But that's just the start of these weekly performances, and we've got a schedule now going forward for each week, bringing in not just other members of Team ASPH, but people from our local schools, community and other volunteers as well. And next week we do actually have one of our local schools coming in to sing, which is really, really exciting. So if you are a budding pianist or singer or can play any particular instrument, we'd really like to hear from you to be able to come in and help us with this for our patients. Another aspect around our live music is actually getting into the ward areas as well, as something we did start at the beginning of COVID, but we've now started again. And last week we had a performer come in, again from Music in Hospitals, a guitarist who was playing on our some of our wards actually, and I have to say the feedback we had from patients around this was really fabulous, and I think the big thing for us really was that they loved listening to the music as it was being played in the ward areas, and for them it actually took away the why they were actually there, and obviously the fact that they were unwell and receiving treatment. So it has huge benefits. So really an exciting stream of our programme. Next slide, please. The next element of our programme is around visual arts, and our visual arts programme has seen the purchase of new items of art throughout the trust actually. We've completely done an overhaul of what our art pieces look like, bringing new art into the organisation, but also purchasing some really specific pieces of art, which actually you will have seen on a previous slide that Marcine had. We've introduced basically nature pictures within our urgent and emergency care area that is situated. They're quite large pieces actually, which are lit up, and I show a particular scene, which is where our patients are waiting to either see a doctor or maybe a nurse. Again, a place where there's quite high anxiety. And what this has done is really, again, the feedback we've had from these pieces of art has been that it's relaxed them, and it takes their mind off where they're at and what they're actually waiting for. So again, a really great piece. If you just go on to the next slide, this just illustrates some more of the examples of our art that we've brought in. And the nature one of the examples of the nature of art that we've got is that below piece that you can see there. Next slide, please. So the third strand of our programme is around the environment. And the Healing Arts takes an integrated approach to art and design in order to create a therapeutic internal and external environments that reflect the trust's cultural context. And some of the projects that we're currently delivering is a new staff garden that will be dedicated to ASPH NHS Foundation Trust staff who sadly died during the pandemic. I'll talk a little bit more about that in a moment, but in addition to this project, we're also got a project underway which is about making our wards Healing Perfect programme, and basically this is transforming key patient areas in selected wards through the refurbishment, including redecoration, new furniture and artwork, as well as activities and equipment to improve our patients' stay. So next slide, please. Another project around the environment is our Eternal Garden, which is, I have to say, a beautiful, peaceful outdoor space. And this was opened back in the spring and is being utilised by patients and relatives of those who are end of life, and for those families who have received bad news. And it's a really peaceful, as I said, beautiful therapeutic setting for people to go to. The actual garden has been designed by Ray Wilkinson, who's an award-winning designer, been at the Chelsea Flower Show. But it basically, the premise of this garden is it's about being in nature and about nature being able to basically give you a hug, wrap its arms around you and give you a healing hug. And again, the feedback we've had from this garden has been absolutely fabulous and very well received. And I just want to say a huge thanks to the Friends of St. Peter's Hospitals for funding this splendid and what is really quite a special place. So the last two slides really are around which I've mentioned already, around our COVID recovery staff garden. And as already highlighted, this is really quite another special place for us, dedicated to those staff who died during the pandemic, again designed by Ray Wilkinson, who designed the Eternal Garden, and is part funded by the Friends of St. Peter. So again, a huge thanks to them for this. But in essence, this is a place for staff to go to really replicate what the Eternal Garden is doing for our patients, whilst also recognising, as I said, those patients who died during the pandemic. And if we just go to the next slide, please. Within this garden, there is going to be a sculpture, quite a big sculpture actually, and this sculpture has been commissioned for the garden by Harry Gray, who Louise already mentioned designed our COVID star that we are wearing. And Harry's taken quite a bit of time to design this sculpture, which you can see on the screen. But in essence, it's about hands, and it's about hands being symbolic, as they were a huge part of the pandemic in so many ways. And as you'll see on the screen, the sculpture is of two hands, the lower hand being the supportive one to symbolise the NHS, and the upper hand being a patient's hand. The NHS hand wears the NHS glove, and this idea celebrates the contact, support and touch of the NHS staff, which truly did, help the nation. Also within this garden, to pay tribute to those staff members will be 5 stars, again designed by Harry. And they will be placed within a bench actually within the garden. So as I've said, this particular project is another exciting prospect, and thanks again for the Friends of St Peter's for part funding this, and also the ASPH charity. And the opening of this garden is going to be on the 23rd of March next year, and that marks obviously 3 years of us going into the lockdown with COVID. And I'm delighted to say we'll be opened by Dame Ruth May, who is our Chief Nursing Officer for England. And I think, yes, we're very excited about that, and lots of work is underway, as I said, regarding this garden. So that concludes the presentation on the Healing Arts programme, both myself and Marcine. I will now hand over to Julie for the look ahead. Thank you, Julie.
Lovely. Thank you very much, Andrea. So absolutely, as Andrea says, it's my privilege to have a little look ahead and emphasise some of the key projects that we are working on. So if I have my next slide, please. There's some brilliant pictures up on the screen now, so thank you. So yes, as the annual report covers activities that have taken place in the past, we just really wanted to take this opportunity to bring you up to date. So you've got a mixture of wonderful photos there. We finalised our green plan and have started to implement various projects, including a site tidy up Womble Day. And yes, your eyes do not deceive you. That picture on the top left hand side of the screen does have a couple of wombles in it. We did have a couple of volunteers. We didn't make them dress up in wombles, but it was really our sort of Womble tidy up day for those people who can remember back to the Wombles of Wimbledon. And Tom and I there in the middle of it, all supported by staff and non-executive directors and governors and volunteers as well. So we had a really good day, and we've got more of that in the pipeline as well. Other green initiatives such as reducing plastic waste and reducing single-use cutlery and cups, and more recently installing some electric bicycles and e-bike chargers at the St Peter's site. So looking forward to using those, but I think for me it'll have to be a fine day for using those bicycles, but that's really exciting. So work continues improving the working environment for our staff, and we've heard a lot of that from our executive colleagues, focusing on the staff well-being, dedicated areas for staff to have good downtime with our wellbeing hubs, and award-winning catering that you heard from Louise. And the top right-hand picture there reflects our amazing catering team, the Eternal Garden and the new staff garden that Marcine and Andrea have spoken about as well. So lots of work that's ongoing. We've had the phase 1 of our new staff accommodation. That's all complete. That's in the sort of bottom middle picture there that you can see. And phase 2 will be complete in 2024. This provides modern, affordable accommodation on site for staff and students, and that's really important to us. So we show our appreciation to staff. It is an absolute priority that we recognise them for their efforts. We've talked about our Staff Achievement Awards, which was a fabulous afternoon. We've also got our Long Service Awards, and we take every opportunity to thank all our staff for everything that they do. If I could have my next slide, please. So I think Simon made mention of this, the Surrey Heartlands Elective Centre at Ashford Hospital, really exciting. So during and after the COVID pandemic, elective waiting times have absolutely increased, and we heard from James around our 18 weeks and our referral to treat backlogs. In response to this, the government has provided funding to help tackle this particular challenge. NHS England delivery plan for tackling the COVID-19 backlog was published in February 22 and absolutely places surgical hubs at the centre of transforming the delivery of elective services. So we wrote a business case that was submitted in June 22, really as part of Surrey Heartlands, so as the county of Surrey, to seek funding to build an elective centre at Ashford Hospital, so that we could use it for all our patients across Surrey. Pleased to say that approval of the 10 million was given to fund the first phase of the development, and that was approved in September. So plans are afoot and being pulled together to mobilise that new centre. So the focus for the elective centre will be around improving patient care with several clear benefits. And these include additional modern surgical capacity to achieve a rapid reduction in planned care waiting times, care from a standalone elective site, and we've heard the strength of that through COVID with the use of our Ashford site, when it's separate from an A&E department, ensuring that there is minimum disruption to any planned procedures so they don't get cancelled, bringing clinical expertise together into one centre of excellence, and reducing health inequalities across the county. So it's fair, open access for all. So the elective centre will also complement an agreed investment in cancer and surgical innovation at the Royal Surrey County Hospital in Guildford. And these two centres will treat patients from Surrey and neighbouring regions, absolutely increasing our capacity and providing our communities with better access to the specialist care that they need. Could I have my next slide, please? Thank you. So this is all about our workforce. So a lot going on in developing a sustainable workforce for our hospitals. So our team are actively working with our partners, and you heard about our partners from Tom within the North West Surrey Alliance, to develop a pipeline of school leavers who absolutely want to access jobs within the hospital and care setting. And this is our grow your own strategy to develop and recruit our youngsters and share with them the wide variety of jobs and career opportunities that are within the NHS and also our partner organisations. It's early days, but we've had a really good response from our system partners and are engaging with local schools and colleges and working out ways to raise the profile of working within the NHS and social care. And hot off the press, a number of us were down at the Brooklyn site last night for the Innovation Academy, which was incredibly exciting. And we heard all about the amazing opportunities for young people to get involved in science, technology, engineering and maths. And that was a really wonderful event that several of us were at last night. Could we just move on to my next slide, please? Thank you. So community open days and members events. So we're delighted to announce that we have plans to hold a community open day in 2023. So we held a community open day the last time in July 2019 before the COVID pandemic, which was a great success. So we're really looking to hold one next year, and we would absolutely love to hear from you, our members, on what you'd like to see as part of that event. So generally, an open day is a special day when we open our hospitals and showcase the amazing things that go on there. There will be stalls and activities for visitors with staff on hand to provide tours of the hospital and lots of interactive activities. We'll also work in conjunction with our partners, including the Army Reserve and Cadets, the Surrey Police, the South East Ambulance Service and the St John Ambulance Service. So we would love to hear your ideas in terms of what you'd like to see and help us put something together. We're going to put a working group together, so please use the email address that you see on the slide to let us know how you would like to get involved and what you'd like to hear. Similarly, members events. So clearly in COVID, we haven't been able to open the hospital as much as we would have liked and to have our members in. But again, we'd like to hear your views as members, what sort of events you might like us to put on. In the past, these have happened on a regular basis, and we've often featured a specific area or a specific department that you would like to hear about. So again, we'd really like to hear from you what you would like to see, what you're interested in, what you want to find out more about in our hospital. So again, please let us know, and we'll try our absolute best to pull something together for you. So thank you for listening, and I think it's time for me to hand back over to Andy, and we're going to open up to the floor for any comments and questions. Thank you very much.
Thank you, Julie. So I'm going to be your MC for this next phase, which is, as I said at the beginning, we're going to first handle our questions that we've had submitted. Then comms will let me know if there have been any questions in the chat. I haven't seen any. And then we'll open it up to the floor. And please do use the little yellow hands, which is under the reactions tab on Microsoft Teams. But we'll do these one question at a time. So the first question came from Jonathan Cole. When I arrived at the hospital, I was asked to fill in a 5-page questionnaire. Every question had been either asked by my GP or basic data like gender, age, etc. Stuff that's on my NHS app. We hear about lots of money being spent on IT systems. This simple information transfer does not seem to work or is unnecessarily duplicated, clearly wastes time. I would ask the question, why after so much money spent on systems and management are simple issues like this not addressed? So Julie, would you like to take that question, please?
Thanks, Andy, and thank you, Jonathan. A really helpful question. I'll make a start, but I will probably, there's a bit of an echo. Is that all right? Can you hear me? I'll probably hand over to Simon, who's our digital expert. I mean, it is incredibly frustrating, isn't it? You would absolutely like to think that primary care and the acute are absolutely joined up in terms of you input one lot of information and it should absolutely be transferred into the next place that you access care. And I certainly use my own NHS app and it has all my information. We have launched an electronic patient record system, but in terms of how that interacts with primary care and the NHS app, I think there's definitely more work to do. So I wonder at this point if I could hand it over to Simon, and Simon could perhaps update us in terms of what the potential plans might be in terms of the future to reduce this duplication.
Yeah, thanks, Julie. So just checking there wasn't an echo. Yeah, it's a really exciting time, obviously, and with the electronic patient record, we can now share kind of basic information, but some of the more complex stuff as well. So already we can see GP records and they see ours. What we don't do particularly well, and it is the biggest bugbear, that's what I'm trying to say, out there, which is how patients give information to staff, and it annoys both sides, having to ask those questions as well as having to answer them, I think it's fair to say. But particularly over the next 6 months, through the NHS app as your source app really, or access to NHS services, you will be able to see your records. We'll be able to ask questions maybe online, so that might be a pre-assessment question, for example, and you'll be able to book and change appointments and those sort of things. So we are getting to the point now, after all that investment, that we can genuinely share that information, streamline our processes and take out the paper. I think there is still some paper out there, and you were probably asked for some of that information simply because that's how it's always been done. But over the next 6 months, it will not be done in the same way, and you will start to see those changes. So we all really look forward to that.
And I think I ought to ask if Jonathan's on the call, if that has answered his question.
Jonathan, unfortunately, wasn't able to join us this evening, but he wants to put that question. Okay,
thank you very much, Anu. Okay, so we'll move on to the next question. Hang on a second. Whoops. Julie, did you want to say something?
I just thought we've got a question in the chat that's kind of that's related to this. I just wondered, well, we've got our Simon digital lead here, it might be helpful to just dovetail that. So can the Cerner system link to the Epic system at Frimley? Dr. Jan Whitby.
So In part, it will be able to do so better in future, not necessarily in the next 6 months, but probably over the next year, once those different systems are completely joined up. But areas like pathology, for example, are seamless. Imaging will be another area that will be increasingly seamless over the next year or so as well. So that is moves ahead in that direction, and it won't be that long, but yeah, soon.
And I think there's yet another one, Julie, on this same topic about will you be able to check hospital appointments in the app? Yeah,
so the NHS app will be your kind of go-to app. We'll have a portal behind the scenes which links to that and links to the Ashford and St Peters and Royal Surrey systems. But yes, you will be able to change your appointments, rebook them, reschedule them. We think from the summer of next year. We'll give you an exact date.
Is that only
in the summer?
Is that only for one hospital?
No, at that point, Anthony, that will be for the Royal Surrey and Ashford and St Peters patients, as well as GP practice appointments. In due course, although I'm not certain of the dates, it has to be said, you will be able to access Frimley, for example, and SABP, so the mental health provider, those sort of things in due course. But there isn't a firm timeline on that I can announce at the moment.
No, I was thinking about, say you had an appointment at St. Peter's, but also had an appointment at Ashford. Would you be able to access both the appointments on the same app?
Yes, absolutely. In the same place, on the same screen. And we would hope that you'd be able to move those that are on the same site. For example, lots of people try and time their appointments, don't they, to make it simpler and more convenient and those sort of things. You'd also access to certain virtual services around there. We'll also be through those sort of apps in future. So it's a really exciting time and lots of changes afoot. So we look forward to those.
Okay. Thank you for that, Simon. So we're going to move on to the next submitted question next, and then I see there's questions coming in the chat as well. So the question is about the, and I'll put inverted commas around this, the crisis in AED, Accident Emergency Department. What has been done to help ease the situation? I think we've covered some of this, but Julie, did you want to take this on?
Thank you, Andy, and thank you, Gloria, for the question. I will hand you over to Dr. David Fluck in a moment, who's leading on our urgent and emergency care work. But absolutely recognising what you say. I mean, I don't think we call it a crisis. I think we recognise that our urgent and emergency care department is incredibly busy, and we can all see that when you put on the news and read the papers. We are focusing very much on urgent and emergency care because we recognise how important it is that the public can access urgent and emergency care in a timely and an effective way. We've put in an initiative in terms of how we are working across the North West Surrey Alliance. So we're working very collaboratively with other providers of urgent and emergency care, the urgent treatment centres, and how we can ensure that the right level of service is available to you when you need it. We've done lots of work in terms of recruiting additional doctors, having a really effective triage at the front door so that you can be identified really early on in your urgent and emergency care pathway and be orientated to the right area to get the care that you need. And you heard some work from Andrea earlier on. Or was it James? I can't quite remember. Lots of work that we're doing around ensuring that only patients who require admitting and will benefit from staying in the hospital come into the hospital. Otherwise, we support those patients through ambulatory pathways wherever possible. And we're being supported really well by social care through North West Surrey Alliance, so those patients can safely leave the hospital. But I can see David on the screen, so I'll hand you over to David, who's our lead for this piece of work. Thank you, David.
No, thank you, Julia. Julia, I think you've mentioned most things, but I suppose just to tie them together, I think it's we've invested in infrastructure. So James talked about us building new modern space in terms of the clinical assessment unit, the ambulatory emergency care unit, which now houses the urgent treatment centre, which is a much better environment, as we heard from Martin and Andrea. That's very important. We've invested in people, so we recruited more ED consultants. We had a very successful campaign in recruiting senior decision makers for the urgent care pathway, particularly ED consultants, and we've moved from having 6.8 whole-time equivalents up to 14, which is a really magnificent step forward. As Julie was saying, we've invested in different processing pathways to make sure people get in the right place more quickly to see the right team. But I think, as Andrea's spoken about and Julia's mentioned, the big investment that we've done is the change in culture, and that is about recognising that patients do come to our emergency pathway because they need care and support, but a lot of time an admission is not in their best interest. We need to make sure that we signpost and help and direct and give them support so they can return home safely and as quickly as possible. And I think it is worth just mentioning again, I think the relationship we've built up with the system, with the North West Surrey Alliance, is absolutely fantastic. And I think we are leading the way in our area in showing that only when you work cohesively and collaboratively as a system can you look after people and get them home when they've been in hospital safely and quickly as possible. And that's allowing us to realign, as Andrea mentioned, our bedded capacity or a support capacity to a community and home-based strategy, rather than always keeping people in beds in hospital, which exposes us to some risk if we're not actually helping with their care. Thanks, Julia. Thanks, Andy.
Andy, you're on mute.
Thank you. Always, you have to have it once at least, don't you? So the question 3 is from Brenda Sharma. In the light of the current social, political and economic upheavals, some of which man-made, some through market forces, how well is Ashford St Peters placed with the impact covered with the ever-present COVID-19 and winter flu? And actually there's a question in the chat as well about, are we seeing a rise in winter flu? So Julie.
Thank you, Andy, and thank you, Brenda, for the question. I'll be brief because I want to hand over to Tom, and I know that we're stuck for time. It's all about the planning. It's all about winter planning. This team at Ashford and St Peters have done amazing work through COVID, and what we've learned in terms of resilience and how we get ready for winter, for COVID-19 and the flu and our booster jabs and all the things that we need to prepare. But I'm going to stop talking because I fill the space otherwise. I'm going to hand you over to Tom, who will be able to update you in terms of our planning, and then maybe Andrew might just, or David might want to just update in terms of levels of flu that we're seeing. Thank you.
Thanks, Julie, and thanks, Brenda, for the question. I mean, as Julie says, our preparation for winter is all about the planning, and the planning starts earlier every year. It seems. I think it started in August this year. This is work that James, our Chief Operating Officer, leads, but it's work that we're all really quite heavily involved in. I mean, the planning happens at all levels. It happens at departmental level within the organisation, at trust level. It happens at place level. It happens at Surrey level and at regional level as well. And we work together as organisations at all of those levels, playing our parts within the emergency planning and response mechanism to ensure that we've got all those plans in place and fully buttoned down before we go into the depths of the winter period. The aim for us really is to ensure that we've got our staffing rotas fully populated and that we've got the right amount of operational management oversight at senior level rostered into the organisation at the times when we think it's going to be tricky. And we know when those times are. We know broadly what happens. We know that, broadly speaking, before we go into the Christmas period, we tend to see more discharges because people are very keen to have their loved ones back home, quite rightly. But then we know that as we hit the bank holiday days, as we go through Christmas and as we go into the new year, things get very tricky and very tight. So our planning is all around ensuring that we've got staffing where we need to enable us to keep the hospital flowing, to get people back home, preventing admission wherever we can for the reasons that have already been stated, and enabling us to take patients quickly from the ambulance service so that the ambulances can get back out on the road. We're really fortunate that we have the Ashford centre, because that means we can carry on with our elective programme, and in previous years and in many organisations actually that has to take a break over the winter period so that the capacity can be provided for the emergency activity. We have been running a COVID booster campaign for several weeks now. We're already in the midst of our flu vaccination campaign. We aim to get all of our frontline staff vaccinated, and a very high proportion of our non-frontline. I've been vaccinated. I think all of my trust colleagues have. As has already been said, we've got incredible support from our place colleagues. There is an awful lot of urgent and emergency care provision outside of the hospital, and we really do encourage people to make use of that through the walk-in centres, through primary care, the acute illness clinics that they run, through 111, and the advice that can be provided through that service as well. So yeah, we are planned to within an inch of our lives, and it's going to be tough. Winter is always tough, and as you say, Brenda, with the challenges of COVID and flu and RSV and a bunch of other things as well. Yeah, we know, but we've done a great deal of planning for that. So I hope that's answered the question.
And just to add a thank you to Brenda, because what I didn't read out is she also added, you have my total and profound respect for how you've performed and coped in the past. And I think the only other thing I would add with regard to the beginning of the question is, yep, things are going to be tough financially as well. And those of you who attend our open board meeting will see that you know, we have to work together with colleagues across the whole integrated care system to make sure that we keep our services going, and we work through. But of course, the money that was there for COVID is going, and as it should, and we have to make best use of our taxpayers' money. Just conscious, we haven't. Have we got somebody who can say, are we seeing a rise in the number of flu cases, Julie?
I'm sure we have. We haven't had any particular spikes or peaks, but clearly respiratory, and very much on the paediatric front, we're seeing a lot of paediatric. David, you look poised.
No, I was just going to say exactly what you say. No, we haven't seen a huge rise in flu at the moment, but that doesn't mean that we're not asking everyone to get vaccinated, and that's all your colleagues outside the hospital as well, if they've got conditions. But we are seeing, I mean, again, COVID, our numbers are creeping up just a little bit, so we're going to see this playing through in waves. And paediatrics has been under enormous pressure with respiratory syncytial virus right the way across the southeast, and our neighbouring trusts have really been struggling, that we've been supporting them during this time and over the last week. So like with all things, the viruses, they're very clever organisms, and they change and adjust and adapt, and we've just got to make sure, and it's down to basic hygiene and making sure those measures are in place. So that's one of the reasons why you see in our hospital we're still asking people to wear masks when they come into our hospital, and that's the reason, because this is not just about COVID, this is about all viral infections.
I see that Gloria's got her hand up before we do more from the chat. Gloria, did you want to come back? Was that you who asked question 2?
Yeah, can you hear me?
Yes, we can.
Oh, good. Yes, you didn't ask me at the time. I'm sorry to interrupt now and put my hand up, but the answer that I was given was brilliant. It's good to know that all those things are happening. But my question was, oh, sorry, I've lost you. What have I done? Oh, but my question was a lot more basic than that. When I was last at the hospital, there were beds on the corridors, and really what I'm asking is, has that finished? That's what I'm calling a crisis, with beds on corridors. I'm asking really, has that finished? Is that done? And do we have any thoughts of doing anything like, what do you call it, discharge to assess, or virtual wards at home and stuff like that? That's really what I was asking. I fully appreciate all the the answer that I got, and it's impressive and it sounds as if everything's going well, but mine was more basic. And I had another basic question, which was how long are ambulance handovers taking? Now, I think you may have answered that by saying, I think something was said that that was going well. So really what I'm saying is, do we still have beds on corridors? And is there anything that can be done further to get people out of the beds, like assessing them at home? Or, you know, I'm just asking.
We've got the question, Gloria. Thank you. Julie.
I think I can see David's really keen. This is David's area of expertise. So beds in corridors, DTA virtual wards, and now ambulance handovers. Over to you, David.
So really good questions, Gloria. And there is a huge amount of pressure out there. So we're meeting the pressure, and we have to do more and more all the time. In terms of the specific, are there ever people in corridors? There are still on occasion, and we don't like it. And we're working very hard, and all those things I've put in place are doing our best to reduce those, because it's stressful for the patients and it's stressful for the staff. But we haven't got rid of it completely, but actually we are doing much better than most places. In terms of your suggestions about discharge to assess, yes, we're doing that all the time. That work we're doing with the system. I mean, we had Cherry Jordan, who runs our discharge team, is an absolutely marvelous woman, and she put together a study day with colleagues from all over the system. It was adult social care, it was ambulance men, it was firemen, it was everyone talking exactly about the things about how do we work together to make sure we get people home, because that's the cultural change that I was talking about, Gloria. We need to, and actually we're leading that for everyone, and there's always more that we can do. But I think we're doing a great deal there. And as you ask about ambulance handovers, we do still get delays in ambulance handovers, but we're one of the best hospitals in the area, and we don't think it's right, because the ambulances have a really important job to go and look after people in the community. So they can't just be standing at our hospital when they're not looking after people out there. So Gloria, the answer to your question is, we haven't solved it all, and there's a lot more that we need to do. But we are really doing our best, and I think we're doing some great stuff, actually. And I think we're demonstrating that we're not throwing our hands up and saying we can't deal with this. We're trying to work out how we can do it.
Excellent. Thank you very much.
Yeah.
Thank you.
And just to say, things like stats on ambulance handovers are in our board reports. The board reports are published, and in the performance report, and the board goes through and puts James in particular through his paces every other month when we have a board meeting on that, and we track it very, very closely.
Good. Thank you very much for that. Thank you.
Thank you. So now we're going to go back to the chat, because I spotted a question for Andrea, and it was all about clinical assessment units versus BACU and hygiene. So Andrea, I don't know if you've spotted it, or would you like me to read it out?
I've spotted it, actually, Andy. So happy to. So great observation, and I think, you know, what it does highlight, that, you know, you can have a very shiny new environment and an old environment, and actually, you know, if you haven't got the IPC right, then you know, that's not great. And I suppose what it does highlight is it's multifaceted, really, which does illustrate our IPC strategy. So there is a bit around the environment. Definitely, that's an influence, and the cleanliness of that environment. Then there's the bit about people and people's practices, obviously hand washing, being bare below the elbows, their processes when dealing with patients, and the protective, you know, what they wear from a protection perspective. So really multifaceted. But to answer your question, we do the IPC team. We have a wonderful IPC team that go out and regularly audit, and also our matrons do as well. So in light of your particular comment, I think what we will do is obviously just go and shine a bit of a light on CAU, and just go back to see what their last audit was, and obviously just see what's going on there, because clearly, you know, you've highlighted an observation which we probably do need to look into. I don't know if you want. Is there anything else you want to say, David, on that?
Well, I was just going to say, obviously, I do consider Burge still my ward, so I'm always very proud when people mention how fantastic it is, because I believe it is a fantastic ward. But I've been on CAU lots of times, and when I've been up there, the cleanliness does look good. But what you're raising is a really good point, that it has to be good every single time. And what would be really good if you see this, if you walk around and you see this, draw it to myself or Andrew's attention there, because it's much better if we go and then sort it out, and we can put the learning in place and things like that. That would be really good. But thank you very much for bringing that up, and we will look at that. As Andrea says, we have got a fantastic IPC team, and they go around and they review all the wards, and it's a really thorough check that they do, and they do it in a really nice way, but it's a really thorough check. So thank you very much for that observation.
Thank you, David. There's a very good question about digital exclusion. Thank you, Alan, for this question. Re-IT developments. I'm personally happy with the use of the NHS app for communication with GP, local hospital services, etc. But will there be some, for example, some older people who are not able to access such facilities? I hope you'll be able to communicate with them with traditional means. So I think that is all about digital exclusion, and because it's not just some old people, actually there are people who haven't got smartphones even in this world, can't afford them, so there are people out there. So Julie, do you want to signpost this one?
I think Simon's given a reply, and Alan's acknowledged it. I think. Okay. I think we're basically saying that we're flexible and adaptable, and we recognise that one size doesn't fit all. But clearly, you know, where people want to access a digital virtual solution, then we'd be really keen to try and promote that. Simon, is there anything else you want to add?
Yeah, just to say, we spend a lot of time booking, rebooking. I was going to say not answering phones, because I think that's the reality of what patients experience a lot of the time. And so we can use digital to reduce some of that pressure, to enable our normal services to be better, I think is kind of my view on this, and to be more responsive, and to put more time into those patients that are challenged in one way or another, or just need more time. So yeah, I think it bodes well, and the technology will help us to meet everybody's needs more appropriately. And the only thing I'd say is sometimes the phone isn't, I mean, it's clearly not the best if you've got hearing challenges. Some of our written communication can be very late in the day, which doesn't help people make an appointment, leads to did not attends, those sort of challenges. So it's a great opportunity to be much better. That's the way I prefer to look at this. Okay, thank you. So we've probably got a few minutes left. If there's anybody else out there, we've tried to cover most things. It's been a bit of a gamble through, but I think Julie and her team have done a sterling job, plus the healing arts, which I hope you're really interested in. So if anybody's got any questions, please do put up their yellow hands, and we'd be happy to take those. Let me just see. Oops. Right. There's B is number 1, and then Tony is number 2. So B.
I had an experience in St. Peter's. I have to confess I'm a bit of a frequent flyer there, even in corridors. That indicated to me that GPs, I personally believe, unnecessarily send people to A&E. I don't know what you feel about it. I don't want to put the blame on GPs. They obviously have got their own concerns about things. But I spent 12 unhappy hours in the corridor, having fought tooth and nail with my GP not to go to A&E, obviously clogging up your system. And I just wonder how much communication there is between GPs and the hospital A&E. I mean, you cannot afford to have people like me lying around in corridors.
But can I say that is an admirable kind of viewpoint? Julie, do you want to comment about our comms with GPs?
Yes, absolutely. And B, thank you for your feedback. I mean, I'll ask David to comment in terms of answering your question more broadly, but clearly the work that we are doing in terms of urgent and emergency care and how we work with GPs is right in the front of all the work that we are doing to support patients so that they can access the care that they need in terms of urgent and emergency care. And we do absolutely work with our GPs primary care, and we've all been talking and making reference to the Northwest Surrey Alliance. So this is very much about how we can support GPs to continue to support patients wherever possible as close to home. So in the community, at the GP surgery, in the neighbourhood, these are all terms that we sort of use. And wherever possible, we are really, really keen that our acute services can reach out into the community and support our GPs so that they can support you closer to home, because we absolutely don't want individuals like you in our department for a long time. We want to support the capacity wherever possible for people who need access to that urgent care, but where we can, how we can support primary care. And that is absolutely work that is ongoing, but clearly there is more work to do. David, I don't know if you want to come in and expand on this point.
I think you've said it all, Julia. I mean, it's challenging throughout the whole system. So it's challenging in primary care, and it's challenging with us. And I suppose, as Julia says, what we've got to do is work out how we can do this better, because we need to work out how we use our current resource and look after people in a better way that, as Julie says, gives them what they need when they need it, and in the best place, which is closer to home. You know, our emergency services, we have primary care within our A&E footprint with the urgent treatment centre, and they do a fantastic job for us in looking at people. But you are right. We need to work out how we can care for people without bringing them up to the A&E department, but delivering the services close to hand. So I'm sorry you had such a torrid experience. And
could I make a suggestion? I'm from the continent originally, and I certainly, you know, sort of 70 years ago was brought up to look after my own health. So it's the 80-20 divide is get the population healthy from an early age, keep them healthy, so you don't overload A&E when they get to their 70s. So it's, you know, perhaps a shift in what we do in the education of GPs and their patients to be responsible for their own health.
Yeah, I think it. I mean, I absolutely agree with you, and I think it's even. I think we over medicalize people's care.
Yeah.
We're too paternalistic in this system.
Yes.
And actually, we have to recognise that hospital institutions like ourselves and primary care, we're only a small fraction of the health of the community, and we need to support people in the community to live in warm houses, to have heating, to have education, and all those things. So I absolutely agree with you. And we've been working with Well North Enterprises in the place-based system for that very reason, that we need to adjust the resources. And if you remember when I was talking about how we're planning to work, how we're working with the Northwest Surrey Alliance, it's not only about health, but it's really changing where we put all our resource. So we can't just put it all at the end of the pathway.
Exactly.
I've told the story. I've been a cardiologist for many years, and it took me a long time for it to dawn on me that I spent my whole time waiting for people to become very ill and then try to save them at the last minute. And we need to organise ourselves in a very different way.
Yes.
But that's going to take us time.
Yeah, but if there's anything that patients can do to help, you know, because I came to this country and I found everybody was abdicating their health to their doctor. Yeah. Rather than taking charge of it themselves. It's rather like letting somebody else drive the car.
Yeah.
And it's got to start with the children. And, you know, one of the initiatives that we've got as a trust, and Tom is leading on many of these, is working with local schools. Because if we don't start with the children, you know, then you end up with diabetes, you know, obesity, and all those things that absolutely add to that. But it's a long path, and you know, Well North and Lord Andrew Mawson has been working with us. You know, they started doing this in Bromley by Bow I think it's 30 years ago now, David, or something like that.
In the 80s, yeah. In the 80s.
Yeah, so it's a long path, but if we don't start on it,
why don't we see picture books or body parts in children's kindergartens? You know, it's
exactly
just learn to name it so that, you know, you can more easily diagnose things, because children will say, this is my shin, this is my elbow, you know.
Exactly. So B, we've got to move on because we've got another two questions to fit in, but thank you ever so much for that question. It was a really good one. Thank you. So we'll take the final two questions, one from Tony and then one from Richard. Thank you. So Tony.
I'd like to thank all the panelists for their open and honest situation of where we are today. I am one of those patients that's been dependent on the health service prior to COVID, during COVID, and now have hope that we are actually looking at the patient at everything we do. So thanks for the update and giving me hope for the future, because I am feeding my lived experience and have sympathy with the challenges we face with all the constraints that are going on, and look forward to that open day in March where we can all celebrate what we've achieved. And don't hide behind legislation, follow good practice and put the patient at everything we do. Work as a team. And we started that in 2016. COVID put our first challenge, but COVID hasn't gone away. So we've got to learn from that and change the way we work, as the previous speaker or the question asked, which was an open and honest discussion. We do the best we can and we treat people with respect and dignity as best we can. So thank you to everybody that's been looking after my care and the people that I help as a navigator.
Tony, thank you very much for that. We really
knocking on that door in March.
Yeah, it won't be March, by the way. It's summer next year we're aiming for. We haven't quite landed on the date yet, but it'll be in the nice weather, hopefully. Richard, you get the last question.
Well, actually, it's Philomena because we're sharing a screen.
Oh, okay. My apologies.
No, that's fine. This isn't a personal experience, but it's one which I witness from being in my local doctor's surgery and pharmacy, and I've heard many times, and it's also the experience of a few friends who've been to St. Peter's and for various different things, one of whom had a mini stroke. They're then released and given whatever medication, but asked to go to their pharmacy, or sorry, to go to their surgery, get repeat prescriptions or get other medication. There seems to be a disjoint when they actually contact the surgery or the pharmacies, that they don't seem to know what they're referring to. And it can lead to a lot of distress. I've actually seen firsthand in pharmacies and surgeries where people are getting very distressed, and quite often it can happen over a weekend where they don't appear to have sufficient medication. And it was just something that I thought about, how if GPs can access or vice versa, or to just sort of streamline this, so to reduce the anxiety on the part of the patient.
David, do you want to take that?
Yeah, so all patients who are discharged home should be given at least 2 weeks of medication. So if that hasn't happened, then we need to understand that. And all patients need to have a discharge summary, and that is given to the patient and also transmitted to the general practitioner. Now, we did have some issues with discharge summaries when we introduced Cerner, which we largely ironed out, Simon, haven't we? But it's not 100% perfect at the moment. But those are the two things. So it would be good to get those. If you have people who've had those issues, we do need to look at that and see how that is and understand where the breakdown in communication is, because that's the process that we should be doing. And if that hasn't happened, we need to understand, because something's gone wrong with the process.
Yeah.
Yes,
Julie,
okay.
did you want to say anything more?
Thank you. The only thing I was going to add was obviously really helpful to have the details, and we can follow that up. And of course, we do have joint pharmacy posts who work both in primary care in the community, in GPs, and also within the trust. So it's absolutely something we could pick up through that route and with our pharmacy lead in order to investigate and make sure that we've just got a really good process in place. So as David said, it shouldn't have happened, and I'm sorry that it's happened. And if you're happy to share some details, then we can investigate. But we've already got those kind of integrated posts in primary care, so there is a route there that we can work through in terms of solving this.
Yeah, okay, that's fine. No, I just thought I would just share it with you because it's not a personal experience at all. Okay, thank you.
Thank you.
Thank you.
So we're going to bring it to an end, but I've got some thank yous to do first. It's not many years that I think that we have 3 chief executives in a year. And I want to say, first of all, thank you to our long-serving chief executive, Suzanne Rankin, who we've exported to Wales, part of God's country, of course. So although not so good at football, as we found out last night. So a big thank you to Suzanne Rankin, very long-serving as chief nurse, then chief executive. I also want to give my thanks to David Fluck here for being a brilliant interim chief executive, not just between Suzanne and Julie, but actually during COVID, when Suzanne was seconded. So my thanks, David, to you. And also to Merrick Vivas, a non-executive who retired, that was replaced by John Machin, if you remember, 6 years of service there, and Chris Catley, who will leave us in February. I also want to say a big thank you to the team that's put this on, the comms team and governance teams, always working really hard, and to all our speakers. And finally, it's going to be my last annual members meeting. I'm due to finish my 6 years at the end of August, and just to say it's been a pleasure and a privilege to be your chairman and to host these meetings amongst many other things. So thank you. Tony, you've got your hand up. Is that something you wanted to? You're muted. We can't hear you, Tony, at the moment. Sorry, we're gonna have to leave that because we can't hear Tony at the moment. But thank you all finally for coming to this. I hope you found it useful and informative. You're most welcome, of course, to attend our open board meetings. Details on the website of how to do that, and indeed all our reports are up there. And please do remember Julie's plea. Ideas around the open evening, ideas for future members events. We really, really want to hear from you. So thank you very much for that. Thank you. And good night.
Thank you, Andy.
Thank you. Bye, everyone.
Thanks, everyone. Bye-bye. Thank you, Andy.
Bye.
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 Bye, everyone. Bye.
Bye.
I wonder who will take over from Andy then. Will they look